But if you're here to listen about improving access to mental health care, you're in the right room. And I would say, for the purpose of this meeting and gathering, welcome everybody. If it is true, which we know, and Jerry Rosenbaum, who's right there, who said this line, and see if I get it right, if your family did not get in any way impacted by mental health problems, it's like winning the lottery. Is that about right? So no family goes untouched. You know that because you're here, and we're talking today about access to mental health care, and I think one of the great enthusiasms, I think, for those in the council through the years is that you've been fortunate enough, sometimes after a lot of struggle and missed connections, to find yourself availing mental health care, quality mental health care, and when it's good, it works great. To find it and to find competent clinicians is a huge challenge. I'm not going to take time from our speakers today except to some statistics which always amaze me, such as 50% of the counties in the United States don't have a single psychiatrist, and that might even be an adult psychiatrist. Forget about it if we're talking about child psychiatry. And this is a relatively newer but trending fact, which is fewer than 50% of clinicians, particularly psychiatrists, are these days accepting third-party payment, insurance payment. So when you talk about lots of mental illness, fewer to offer help, what's the quality of that help and how do you know, and then can you pay for it? We have a real, I don't like overusing the word crisis, but for those of you who are in it, or friends of yours who've been in it, and you're told that the waiting list for your kid to get help might be for their next school year, then you've got a lot of suffering and worrying, and those who are parents and family know what that's like. So we're going to talk a bit about this today with our speakers, and also if you do think about asking questions for when we're done. We're not going to do questions after each talk because each talk will take us to the end. So we'll go through our three speakers, then open it up for what your questions are. So again, thanks for your attention to this, for me, really very important topic. So our first speaker here is Felicia Smith. Dr. Smith and I have known each other since she was a resident, and before she was a resident, and now is running our consultation service, which is perhaps the most famed service of our Department of Psychiatry, the most integrated into our hospital. She is Director of Division of Psychiatry and Medicine and Chief of the Consult Service. She graduated from Middlebury College and University of Vermont, completed residency at the MGH training program, and then did a fellowship training in consultation psychiatry called psychosomatic medicine. And she's committed to the care of those committed with psychiatric and medical illness, as well as to the medical education. And she's here to talk to us about the mind-heart-body connection. Felicia.
Thanks very much, John, and thanks so much for having me today. As Dr. Herman mentioned, I'm going to be talking about the mind, heart, and body connection and what it means for your health. Before I do that, I'll say a little bit about what I do at Mass General. Dr. Herman already alluded to the fact that one of my main roles is directing a service called the Avery Weissman Psychiatry Consultation Service. What we do is we see patients when they're admitted medically and surgically to the hospital and when a mental health issue comes up, both adults and children, though I run specifically the adult service. We see about 15% of all patients who are admitted to the hospital every year. That ends up being a very large number, over 10,000 consults per year. and we're one of the main teaching and academic services in our department. So why did I choose to talk about this today? Well, as a consult psychiatrist, I see a lot of patients coming into the hospital with cardiovascular disease. That makes sense. Cardiovascular disease worldwide is unfortunately still the #1 killer of people, killing about 11 million people per year. And when I'm talking about cardiovascular disease, we often think about the heart, but we should also remember that cardiovascular disease affects many different organs in the body, and in particular, the brain. If you think about stroke and dementia, cardiovascular disease actually can be even more detrimental than just when we're thinking about the heart specifically. Now, humans have known forever that the mind, the heart, and the body are connected. If you think about the fact that when you get anxious, for example, your heart starts to race. My heart's racing right now. In most situations, that's adaptive. If I needed to run, hopefully I won't run, but if I were in danger and I needed to run, my heart beating faster serves to pump more blood to my legs, and then I can run and get out of a dangerous situation. Over recent decades, though, there's been more and more scientific inquiry and studies to look at more negative consequences. For example, people who develop depression, anxiety, or have chronic stress, and that there can be more deleterious consequences in terms of cardiovascular health. So that's one of the main things we'll talk about today. And as Dr. Herman mentioned, because of that, the good news here is going to be that we can actually treat a lot of these conditions, as you know, and improve cardiovascular health. But because of that, treatment and access to care is really going to be key. So let's start off by talking about a case. So this is a case of Jane, whose name has been changed, but it's a very typical patient who we'd see on our consult service. Jane's a 67-year-old CEO, recently retired actually, went with her husband on a trip to Mexico, where she started to notice that she was getting short of breath and also had some indigestion. And she thought, oh, I'm out of shape, that's why I'm short of breath, and I'm eating a lot of Mexican food, that's why I have indigestion. But then she started to feel significantly worse, started to have some chest pressure, made her way back to Boston. By the time she came to the hospital, she was unfortunately having a heart attack. So she got admitted to the hospital, and our colleagues in cardiology noticed that Jane seemed particularly angry and really discouraged. So they consulted us. Again, a pretty typical consult. When we saw her and talked with her, sure enough, she was experiencing a lot of anxiety. She was having anxiety about her retirement, wondering if she was actually going to have enough to do, and also now anxiety about the fact that she'd had a heart attack. And she had experienced some pretty significant chronic stress in her life as a CEO. She wasn't sleeping well, her appetite was poor, her energy was poor. She complained of feeling depressed. And interestingly, she had been really looking forward to spending time in her retirement with her grandchildren, and she wasn't looking forward to that anymore. So we thought that Jane was, in fact, depressed, and we'll talk a little bit more about how we proceeded as this goes on. We'll remember Jane as I talk further. As we think about psychological health in this way, in terms of its effects on cardiovascular health, we want to think about both the positive and the negative. Now, Dr. Rausch talked about being an optimistic person and always having a sense of gratitude and resilience. Now, as it turns out, that's actually going to be really protective for cardiovascular health. Conversely, some of the negative states like depression, anxiety, pessimism, discouragement, those things are going to be detrimental to cardiovascular health. So one of the main take-home messages here is going to be that if we can treat those negative states and move people toward positive states, then we're going to actually be able to have a positive effect on things like heart attacks. And we'll go into some of that specific data in a minute. In terms of those negative effects, I mentioned heart attack already, so like Jane, but there are many, many studies, too many to discuss here, that show these deleterious effects on multiple different types of conditions related to cardiovascular health. So from heart attack to stroke, to incidence of diabetes and obesity, which are risk factors for cardiovascular disease, to things like heart failure and dementia. So we'll look specifically at one of those, and this is work done by colleagues Drs. Jeff Huffman and Drs. Christopher Solano of the MGH Cardiac Psychiatry Research Program. They're some of the premier clinical researchers doing work in this domain and have influenced the field quite a bit. So I thank them for some of these slides that they've lent to me. So if you look at this slide and you look at a continuum here, you start off on the left with people who've not yet developed coronary artery disease, and then move to the right toward the development of coronary artery disease. Then to the right to having an event, so like Jane, her event would be her heart attack. And then finally to survival. And you see in the blocks depicted that there are multiple different places where depression specifically, and here you could also substitute things like anxiety and anger, but where depression in this case specifically has a negative effect. So for example, people who are depressed are more likely to develop coronary artery disease. They're then more likely to have the disease progress more quickly. And then if you have an event like Jane, survival is impacted in a negative way, more likely to die, unfortunately. So that's the bad news. We'll get to the good news in a minute. But before we get to that, there are many different thoughts and reasons of why this could be the case. And many of these have been tested in the scientific literature. And they range from biological reasons to behavioral reasons. So on the biological side, things like the fact that depression causes increased inflammation in the body, and inflammation is bad for your health. People have probably heard a lot about inflammation with COVID. Depression also causes increased platelet activity. When platelets get sticky, they can form plaques, and that's bad in terms of cardiac risk. Depression also impacts hormonal function in a negative way. So that could be particularly important for perimenopausal and postmenopausal women, for example. On the behavioral side, if you're depressed, if you think about it, it's harder to eat a healthy diet, maybe harder to exercise, maybe harder to take your medications. People who are depressed are often not as motivated to go to cardiac rehab, for example. So you can see here that there are both potential biological and behavioral mechanisms. Not all of these are present in all the same patients, but there are many different ways that things like depression and anxiety and anger can lead to worse outcomes. Now I promise the good news. So what about positive emotions? Are these beneficial? Can these help? And the answer is yes. So similar studies have looked at what happens if people are optimistic, or they show gratitude, or they're resilient. Well, both those behavioral and biological mechanisms can improve, or can make a difference. So for example, people in those positive states are much more likely to eat a healthy diet, to exercise, to take their medications. But also on the biological side, so studies have shown that if you're an optimistic person, you have potentially less inflammation in your body. So this means better outcomes, less death, less hospitalizations, and greater quality of life. So again, treatment and access to treatment are going to be key. And the good news is treatment works. So medications are safe. So even for someone like Jane, who had a heart attack, medications have been shown to be very safe and to be helpful. So medications, in her case for depression, like a serotonin reuptake inhibitor, can be very helpful. Psychotherapy is also helpful. Positive psychology and those kind of interventions can also be helpful. And I'll finish up here by talking about a specific intervention called collaborative care, that it was also part of a research program by our cardiac psychiatry research group. And what they did was they took a care manager, social worker or nurse, and they sent them to the cardiac units. So when people came in with heart failure or a heart attack, that kind of thing, and they screened everybody. Now, one of the main reasons they did this is that we know from the literature previously that cardiologists aren't always great at picking these sorts of things up. Unfortunately, they're getting better, and they consulted us for Jane, but a lot of patients were getting missed. So they sent the care manager to screen and then to make a diagnosis of depression in particular. And when they did, they helped coordinate the care. And this part was really key, to make sure people got into care, start the care in the hospital, and then coordinate care on an outpatient basis. They also helped longitudinally monitor these symptoms to make sure people stayed in care and that they were getting better. So that's great, but did it work? And the answer is yes, works really well. So you can see the blue bar here. These are the collaborative care patients. You can see this is the patients who had adequate care by the time of discharge. Many, many more had adequate care by the time they left the hospital. So that's great. They had adequate care, but did it help? And the answer is yes, it helps. So this shows in the blue graph on the top, or the blue bar on the top, excuse me, shows mental health-related quality of life in 6 months. So those folks were doing better by quality of life measures. They also had lower levels of depression, as shown on this graph. And they had, and self-reported, greater improvements in functioning. So they were less depressed, they were functioning better, and they were in care getting the treatment that they needed. And in fact, this is what happened with Jane. She was actually not part of this study, but we were able to see her, start her on a medication in the hospital, refer her to care. She continued to get care, both psychotherapy and medication treatment, and did really well. She did well from a heart attack standpoint, fully recovered, and did well from a depression standpoint, and was able to enjoy her retirement and spend time with her grandchildren. So in sum, hopefully I've made the case here that psychological health is a really important component of well-being. I probably didn't have to make that case to you all, but also in particular of cardiovascular health. There are really clear associations between psychological health and cardiovascular disease. I've talked to you today just about the tip of the iceberg in terms of studies. If we improve psychological health, we can really make a dent and improve cardiovascular disease, the #1 killer of people in this country and worldwide. But we really need to focus on access to care and treatment. Thank you. And thanks to Drs. Huffman and Solano.
Thank you, Felicia. As Felicia was talking, I was thinking a bit about what Maurizio had said earlier about this department and its place in the general hospital. And this department, which was established in 1934 by Stanley Cobb, had as one of its first residents a guy by the name of Avery Weissman. And Avery Weissman is the person after whom the consultation service is named. Avery worked in the general hospital. He was also trained as a neurologist, and he worked with a guy named Tom Hackett. Tom Hackett was the chief of our department and the head of the consult service. And one of the stories I was thinking about in his involvement with the cardiac, in the cardiac area of interest is a story he told, which was he was doing consults, and when they had a code, when somebody's rhythm started dropping out and or their heart stopped beating and they would call the team, out would go the sound of a Klieg horn, like when a submarine was diving, loud, enough to give anybody a heart attack who already wasn't impacted. So that was one of his first interventions. I think the point is that as the general hospital, the physicians and the surgeons began to see the effectiveness of our work with their patients, they began to refer their outpatients to us, and then their family members to us, and then themselves to us in ways that were both discreet but effective. And I think at that point, with whatever financial challenges psychiatry may have within an institution, they could never do without us, whether it was for their patients or for themselves. And now we're 750 strong of psychiatrists and psychologists, which has got to be, I'll just say, one of the biggest in the country. So I'm now going to introduce Beppe Raviola. Now, Beppe has trained with us in adult, trained at Dartmouth in child and adolescent. Beppe worked with the recently and sadly and tragically deceased Paul Farmer. His work has been international in Rwanda and in Sierra Leone. And he's now more aware not only of our local challenges in getting access to that care, but of global challenges as well. He's also director of the Chester Pierce Division of Global Psychiatry. Chet was another great teacher for all of us, and as you may see as we talk, there's just a legacy of generation to generation, a family-like feeling within this, within our department, and we consider the council to be part of our family too. Beppy.
Thank you, everyone, and thanks, Felicia. And I think, collaboration is such an important theme that I'm going to speak about directly and indirectly. So this is an invitation to reimagine mental health care delivery and really to think about bridging the world of global health with gaps in the US. And I'm going to weave a story in which I'm going to talk a bit about how we think about weaving those things together in today's world. Dr. Pierce is remembered as a pioneer and a visionary in education, psychiatry, global health, public health. He had all kinds of important ideas about race and poverty in the United States as well. And he inspired us through his deeds and his resilience and his insights and his humility. So we're going to talk a bit about the Chester Pierce MD division of global psychiatry at MGH and our sort of future vision and how we weave together the local and the global, and think about drawing from lessons in global healthcare delivery for the present. So imagine this is the largest medication supply cabinet in the country of Liberia. This is in southern Liberia. That's all the medications, psychiatric medications. Country, 5 million people, 1 psychiatrist. And we developed this cabinet coming out of the 2014 to 16 Ebola crisis in West Africa. So the national pharmacy director comes and sees this and says, that is the biggest medication supply cabinet in the country of Liberia. 25 years ago, I had the privilege of having, as a teacher and a friend, Professor Paul Farmer, who was one of the co-founders of Partners in Health, which is an international healthcare organization that works across 10 countries. We have 20,000 employees. Over the past 15 years, I've used my training both in psychiatry and global public health to build teams to effectively address complexity and comorbidity of mental illness in these difficult contexts. And since 2016, we've had more than 250,000 patient visits across all of our sites, across 105 public sector facilities. So the work is embedded within the public sector of government healthcare systems. And across all the PIH sites, we've implemented the key research finding from the field of global mental health, which shows that community health workers or other non-specialist providers, non-clinicians, paraprofessionals, can effectively deliver psychological interventions outside of health systems in communities. And this practice is called task sharing. That's sort of the wonky term, task sharing. In our work also at Partners in Health, which makes it unique, is that we've also integrated best practices in psychiatry, again, to try to address the complexity and heterogeneity of problems that we see, because often psychological interventions aren't enough. So there's really a combination. And our model has been to pilot best practices for governments and to support government teams in scaling such services. So in Peru here, this is the outskirts of Lima, for example. We've done preventive interventions with mothers and their children around attachment. We've delivered psychological interventions for common mental disorders, but we've also cared for serious mental illness, and we actually piloted a safe house model that has been scaled nationally for young women living with psychosis abandoned in communities in Peru. And our experience in Peru and elsewhere over the past decade has enabled us to take best practices in global mental health delivery, for example, written about by Paul Farmer, Jim Kim, Michael Porter at the Harvard Business School, and translate it into these very useful frameworks where we marry healthcare at the health center level and community level, delivered by psychologists, social workers, community health workers, nurses, and generalist physicians in contexts where there aren't psychiatrists. And just to say a bit more about that, we started in Rwanda in 2009. Rwanda is a country in East Central Africa about the size of Maryland. And with the construction of beautiful new hospitals in rural areas in Rwanda, in a country that had overcome the destruction from the 1994 genocide, that has now a sophisticated healthcare delivery system, there was an opportunity to effectively integrate community-based mental health care. So some of the teams we've built and supported have developed a model of care similar to what Dr. Smith is talking about, where government nurses at health centers are linked to hospitals and effectively evaluate and treat severe and common mental disorders in the context also of medical illness comprehensively. So there's 30 districts in Rwanda. Each district has 20 to 30 rural hospitals or health centers. So we've scaled this model to 4 districts, and I'll just mention that this woman sitting here, she had walked 50 kilometers catatonic to the hospital to get treatment. She got treatment at the hospital, but then through this work, we developed these community-based systems. And the community-based supports are significant, and it includes psychosocial interventions and rehabilitation and evidence-based psychotherapies. And some of the evidence-based psychotherapies we've been implementing in Rwanda and the Partners in Health sites we're now implementing in Massachusetts. Our department now is also supporting the development of a new psychiatry residency at the University of Global Health Equity, and we'll have a clinical clerkship from this October to November. So that's been exciting. In Haiti, we responded to the 2010 earthquake at a very difficult time. This is one of the internally displaced person settlements that cropped up after the earthquake. And we trained psychologists to deliver psychotherapies, generalist physicians to prescribe medications, and we engaged community health workers in delivering community-based care, as we did in Peru and Rwanda. So this is a 21-year-old young man who had been psychotic and did very well with basic psychotherapy and medication. He has a radio station now in his house, and he gives commercials on mental health. And the other key ingredients to this work include a focus on building teams, developing professionally and mentorship and professional development pathways, and then nurturing of partnerships, for example, with Harvard Medical School and with the Pierce Division as well. And these are the ingredients that have contributed to the successful development of a community model in Haiti, which serves around 1.3 million people, or 1/6 of the country. And you can see here, there's very clear community health worker interventions, psychologist and social worker interventions, and physician interventions that are done in the absence of psychiatrists. And then in Sierra Leone and Liberia in West Africa, with the Ebola crisis, we also mobilize community health workers to provide psychosocial support in the context of that particular crisis. This is a community health worker. We had community health workers on motorcycles treating people on the streets. There were many homeless, traumatized, psychotic former combatants, mostly men living on the streets, and the community health workers have treated all of them, really. And starting in 2018, we've rebuilt the oldest psychiatric hospital in Africa, Sierra Leone Psychiatric Teaching Hospital, which opened in 1820 as a TB hospital. And so you can see the president of Sierra Leone here blessing the hospital, and we've opened a residency as well. And then the skills and practices built into the teams we support have made these teams a key resource in other emergencies. So for example, when this tanker exploded in the afternoon commute in Freetown, Sierra Leone, our team was the first to respond. And so the heart of this work really is building capacity at a community level and community members who have the greatest proximity to people living with mental health problems to provide that care. And whether it's in the US or the Global South, the problem fundamentally is one of care delivery systems. So here in the US, we have almost 40,000 psychiatrists, but last year, 42% of people experiencing an acute psychiatric crisis had no access to care. So while the global burden of mental disorders doubled in the 25 years before COVID, and then COVID exacerbated the situation in terms of psychic trauma, exacerbation of mental illness, the economic injury, and burnout among all of us, including healthcare workers, how are we going to address the significant challenges to mental health that our country faces? And so one aspect of the challenge ahead in reimagining mental health care delivery is the fact that the field of psychiatry has to lead. And the one thing I'll tell you about this key research finding of task sharing is that it still requires psychiatric care and psychiatric support. So psychiatry departments such as ours really need to think about this bridging of global experience and global knowledge around this and apply it locally, because global health also happens here in the US, right? And no country is truly developed in terms of mental health care. The US is a developing country in terms of mental health care. Just say a few more things. There was a community tracing collaborative, and I was in charge of the Commonwealth of Massachusetts Contact Tracing Collaborative for COVID. We trained several thousand community health workers in Massachusetts to deliver psychological first aid, one of these interventions. And so that was a very successful effort. We also took another different psychosocial intervention package called Problem Management Plus, and we integrated it starting in 2018 in the Roxbury and Dorchester neighborhoods of Boston in collaboration with the Family Van, which was a mobile health van. And so now we're integrating this kind of work. And so these are interventions that have been done globally that integrate core strategies and best practices and evidence-based practice, but they're not delivered by clinical psychologists. So this is going to be the focus of our work in the Chester Pierce Division of Global Psychiatry. We now have this new Advancing Community-Driven Mental Health Initiative where the Blue Cross Blue Shield Foundation of Massachusetts is supporting us in training community-based organizations in Massachusetts in delivering these interventions. But I want to mention that these are interventions. They're not the framework within which we frame them, but we understand the core components of the framework to deliver these interventions. And so these interventions and these kinds of projects, they embody the spirit of Chester Pierce. And I would argue that we must, as soon as possible, integrate these interventions and embed them outside the health sector. Thank you.
Thank you, Beppy. So I'm going to tell you I don't know if you know this story about the Chester Pierce Division of Global Psychiatry. So one day, Chet was already a giant figure in our department and teacher to all of us. And I was in my office, and he was nearing or at retirement, and sort of reflecting on his time. And he said, I called him pathologically humble. He would never ask for anything. He would never expect credit for anything, yet he had accomplishments in his life which were historic, literally. And so he said, yeah, there's one thing I regret. I've always wanted to have a conference and do a study of the global diaspora, the diaspora from Africa across the world, particularly looking at that diaspora and the slave trade. That was the one thing. And it's sort of, Chet always would say things that kind of, on some level, both came out of the blue and made total sense. So Chet left my office. I walked about 25 feet down the hall, and I went into the office of Jerry Rosenbaum, who was the chief at the time, and I said, Jerry, Chet has something that he wants. And Jerry was surprised. I was delighted to bring the news. And Jerry said, okay, let's do it. And found some money in his coffers, but enough to put on a conference that subsequently led to what was the establishment named after Chet. The last night, we were going to announce the establishment of this division. And in full keeping with Chet Pierce, we sort of knew it because we were going to announce it and give it his name, but Chet didn't show up. Okay, so next is Kate Bentley, who's a psychologist in the Department of Psychiatry and director of the Suicide Prevention Research Program at the Center for Precision Psychiatry. Some people might think that precision psychiatry is an oxymoron. I used to have a joke that if you wanted 2 opinions, just ask one psychiatrist. It can be pretty confusing. But the work that Kate and her group has been doing is enormously impressive and gives all of us some hope that we can do something to prevent that which is the most tragic of outcomes in the care of psychiatric illness. Kate.
Thanks so much for having me here today. All right, so the topic of my talk this morning is a heavy one, suicide. I'd first like to share a little bit about what has motivated me to focus on suicide in my research and practice. I'd guess that I'm not alone today when I say that suicide has touched my life personally. I've had 2 loved ones die by suicide. One was my grandmother, and another was a very close friend. Both of these losses were significant and devastating for me, my family, and our larger communities. Unsurprisingly, given what we know about mental illness increasing suicide risk, both of these people had depression. Perhaps what may be a bit more surprising, though, is that both of them were engaged in psychiatric care when they died, and they also had many other factors in their lives that we think of as being protective. So given this, I've always been left wondering what more might have been done to prevent their deaths. For many people with mental illness, receiving specialty mental health care can be truly life-saving. But for a minority, psychiatric care, at least how it's traditionally provided, falls short. So today I'd like to share a little bit about the work my team and I are doing that aims to leverage technology to improve how we support people who are at risk for suicide. So I want to give just a bit more context on the problem to start. Over 48,000 people die by suicide each year in the US. This makes it the 12th leading cause of death across all ages, and now the 2nd leading cause of death among young people. And also, very importantly, the suicide rate has remained virtually unchanged over the past 100 years. For every suicide death, there are 4 hospitalizations for suicide attempts, 8 ED visits related to suicide, 27 self-reported suicide attempts, and 275 people who seriously consider suicide. These numbers are staggering, of course, and you may also be wondering why they're still so high. There are likely many reasons, but one is that suicide still receives far less funding for research on how to prevent it than the funding that's allocated to many other leading causes of death. Another important thing to note about suicide is that the vast majority of people who die by suicide saw a healthcare provider in the year before their death. This means a few things. First, in hospital systems, we have a clear opportunity to identify the patients who are at highest risk and intervene to prevent their deaths. That said, given what I just said a moment ago about the suicide rate remaining virtually unchanged, there's still a great deal of room for improvement. So our team sees a clear and urgent need to move beyond traditional approaches of identifying and treating people who are at risk for suicide in healthcare systems. Much of our work involves leveraging advances in technology to do just this, and in particular to improve how we identify the moments that people are at highest risks and offer them more timely and personalized support when they need it. One type of technology that much of our work now uses is something that pretty much all of us now carry in our pockets, our smartphones. We're all aware that smartphones have become nearly ubiquitous. Recent numbers show that upwards of 95% of Americans own one. You may also be aware that there's been controversy about whether smartphones, and in particular social media, may actually worsen people's mental health. This is a complicated question with no clear answer, but what I will say is that it's unlikely smartphones are going anywhere anytime soon. So given that they're here to stay, one question my research team and I have is whether we might leverage smartphones to do some good. And in particular, to help us better detect when people might be heading towards a suicide crisis and get them more personalized, timely support during the moments when they really need it. So I'm going to take a moment now to share why we think smartphones might be so helpful for supporting people who are at risk for suicide. One thing we know about conditions like depression and also suicide is that worsenings can happen very quickly. All it can take is a few days or maybe even a few hours for someone to be doing relatively okay, to be feeling more stable, to go to being not very stable or doing well at all. Another thing we know is that there are often signs that a worsening may be happening or about to happen. Some of these signs may be behavioral. Someone may start sleeping a lot more, sleeping a lot less, withdrawing from their family and friends, or not leaving the house. People may often evidence shifts in their thoughts and their feelings leading up to a suicide crisis. People may start thinking that things are more hopeless, like they're a burden to others, or having more intense negative emotions like shame or anxiety. What smartphones, and maybe even other mobile devices that some of you may be wearing right now, like Fitbits or Apple Watches, can do is to allow us to measure changes in people's thoughts, feelings, and behaviors in real time. Whether we like it or not, our phones can now track a lot of information about us, where we go, what we do, who we talk to, and then our Fitbits can track things like our movement, our activity, and even our stress. The thing we're wondering is whether we might take these mobile data that are being collected by these devices and use them to detect when people are struggling and help them get more support when it's needed. So in our team's research, we're meeting with patients who have been hospitalized, and with their consent, we're downloading a few apps on their phone to do just this. We also give them a Fitbit. So we track their activity patterns, their communications, and locations, all during a period that we know to be very high risk for suicide, the weeks and months after a psychiatric hospital visit. Patients also in our study, a few times a day, answer a series of brief questions on their smartphone that look something like this, about their feeling states and also their thoughts, including their suicidal thoughts. Findings from this work so far have confirmed something I mentioned earlier. Suicidal thoughts can change really rapidly. So here I'm showing one study from a few years ago of hospitalized patients. This was work led by my colleagues Dr. Evan Kleiman and Dr. Matt Nock at Harvard. On the x-axis here, you can see time. This is about a 3-day period. And then on the y-axis, you can see suicidal thought ratings from the brief smartphone surveys. Every patient here is represented by a line. There's a lot going on in this figure. It's really messy, actually, which in part speaks to the problem that we're facing. Suicidal thoughts vary a lot over people and over time. One main takeaway, though, is how much variability there is in patient suicidal thoughts over even this very short time period of a few days. This suggests that there really may be a need to be able to learn right away when worsenings are happening, as shown here for the patient in turquoise with these black lines. This also begs the question, of course, of what should happen when we detect that there may be a worsening for someone. Most providers, as we are all well aware, tend to only see their patients every week, every month, or maybe even less, which means that there's really a need to be able to learn sooner what might be happening between sessions. Along these lines, my team and I are starting to use these data from people's devices to trigger more timely interventions. This involves us sending interventions directly to patients when their incoming mobile data suggests that they may be at risk right now. So our work is testing a few different lines or types of interventions. One is our clinicians actually reach out directly to patients to help support them and guide them to get the care they need during these moments of high risk. Another involves sending direct, automated digital interventions directly to patients. This may look like examples from these messages that we're using right now, guiding people towards using their personalized safety plans or practicing evidence-based coping skills for suicidal urges. And then over the past couple years, our team in the Center for Precision Psychiatry, led by Dr. Jordan Smoller, has partnered with Samaritans, which is a Massachusetts-based community crisis organization, to actually connect people in real time with crisis services to help them stay safe. So one ultimate goal that we have with this work, along the line of precision psychiatry, is to use all the data we're collecting to get better at determining what specific intervention is needed for a given patient and when. One thing I also want to note is that although some of the interventions we're testing are automated, our vision with this work is not at all to replace clinicians. In fact, another line of work that I'm doing, this is with my colleagues Dr. Becky Fortgang at MGH and again Dr. Matt Knock, is to actually begin to share these real-time data directly with providers so that they may use the real-time data we're collecting to inform more precision or personalized treatment for their patients. So here's an example of what this would look like in an inpatient setting. On the left here, we have data from about 3 days of patients' continuous monitoring of their suicidal thoughts from smartphone surveys. And on the right, we have an example of a patient's negative emotions and their sleep. One of the things that we're going to start doing soon is to test whether giving providers access to these real-time data actually improves their patients' outcomes. So one final thing I want to note is that anytime we're talking about incorporating technology into healthcare, there are, of course, challenges, also at a systems level. So one thing that we're really trying to do is prioritize partnering with providers and other stakeholders at every step of the way. One example of this is we recently led a series of focus groups with a diverse range of MGH providers on the possibility of implementing statistical models for suicide risk prediction in routine care. Overall, the reaction to this work and incorporating our research advances into clinical care has been quite promising. One provider recently said to us, and this was about the possibility of seeing their patients' real-time data, that it would be helpful, especially if you meet with someone and they're reporting they're not suicidal, and then maybe later in the day, something triggered them to feel suicidal. It allows the team to then make a clinical decision of, do we need to intervene right now? We're also partnering closely with patients to get their perspectives on us doing this more intensive outreach and monitoring. A patient recently shared to us about our monitoring and outreach during the post-hospitalization period that it tells me I didn't fall through the crack. For me, it was like they really do care. They want to make sure that I'm okay. So the last thing I'll note is that anytime we think of, again, incorporating technology, we're not thinking of technology as a magic bullet. Our idea is that this should not replace what we have, but should help us build on it. And so to bring it back to how I started today, do I know that using technology to do this more intensive monitoring and outreach would have prevented my grandmother and friends' deaths? I don't, but I think there's a possibility that it may have made a difference in the days or hours leading up to their deaths. One thing we've learned is that suicide is preventable, and we must continue to strive to do better at preventing this unnecessary loss of life. Thank you all so much.